you all for joining us tonight. I'm thrilled to welcome Dr. Wang from UCLA. He's a neurologist there, or a neurosurgeon there. He's here to talk to us about CCMs. And I do want to request with questions that you can put them in the Q&A. That way we don't overload the chat with it. But we will get to your questions at the end of the presentation. And we'll try to answer them as best we can. But Dr. Wang, the floor is yours.
All right. Hello, everybody. Thank you, Lindsay, for having me. I really appreciate the opportunity to come and talk. I will try my best to get to your questions at the end and get some reasonably intelligent answers for whatever I have. But please feel free to also look me up if I didn't fully answer any questions for you, or if something comes up. I'll be happy to chat offline. I'm going to bring up some slides just to go through to help me kind of illustrate. Okay, so I'm just going to spend a little time going over kind of briefly what what was clinically relevant about cavernous malformations, and then I'm going to spend a little bit of time kind of going over some scientific findings that have been really interesting to me, and hopefully will be for you too. But let's start. Cerebral cavernous malformations are vascular malformations that are found most commonly within the brain. And occasionally in the spinal cord. And while these things can change over time, can cause mass effects just by being there, these are not tumors. These are malformations of blood vessel formation. And most commonly, they will show up by causing, or by bleeding, and some of the stuff that happens as a result of hemorrhage. Such as inflammation or mass effect from the hemorrhage. And then these things are also frequently detected when someone has a seizure. These things can cause seizures in a few different ways. Hemorrhage in and of itself can cause seizure activity. And even though large hemorrhages can sometimes cause kind of acute changes, acute symptoms, sometimes little tiny vessel leaks, which are kind of part and parcel with the natural history of cavernous malformations, sometimes just having those little tiny microbleeds can cause a small local inflammatory reaction, can result in deposition of blood breakdown products, and those can cause brain irritation in the tissue around, which can secondarily cause seizures. So, one of the most important questions about cavernous malformations is how likely are they to bleed? Not only because that affects or that influences kind of what you think of having a cavernous malformation, but it also informs the way that you kind of gauge the risk and benefit of treatment. So there's a lot of numbers published out there, but very generally, the risk of hemorrhage is influenced by the location of the lesion. In the cerebrum, the risk of hemorrhage is about 0.25 to 1% per year. And when you're estimating a kind of lifetime risk of hemorrhage, that's additive. And then in the infratentorial, kind of in the cerebellar or brainstem locations, the risk is slightly higher, but still on the whole, quite low, 2 to 3% per year. Now, after a lesion has hemorrhaged, the risk of rehemorrhage appears to increase substantially. those numbers can vary quite a bit. We think that there are characteristics in certain cavernous malformations that might say one is more liable to rehemorrhage than others. And there is some suggestion that over time, if one hasn't rehemorrhaged, that the future risk of hemorrhage probably reduces a little bit as it goes along. So then, secondarily, can seizures be controlled? So seizures are actually the most common presenting symptom of cavernous malformations in the cerebrum. They it can affect anywhere from 35% to 70% of patients with cavernous malformations. So it's really commonly seen. And the first line of treatment for seizure control is medication. Only about 40% of patients who have cavernous malformations will progress to what we call medically refractory epilepsy, in that we've tried two medications that either are ineffective in controlling the seizures or cannot be tolerated due to side effects. And then in patients who undergo surgery, you can expect about a 75% rate of seizure freedom if you take out the lesion, and really good control of seizures in over 80% of patients. So seizure management's quite effective with surgery. Again, 40% being refractory to medications. And expect about a 75% rate of seizure freedom with surgery. And then there are certain factors that kind of affect the rate of seizure freedom with surgery. Patients who have multiple cavernous malformations predictably are a little bit less likely to obtain seizure freedom with resection of just one cavernous malformation. That the seizures, the focal epilepsy has not secondarily generalized to kind of increasing the excitability of adjacent brain areas. And probably related to that, a shorter time to surgical intervention. In a couple of studies, 1 year was kind of identified as being a statistical cutoff point. And then complete resection of the cavernous malformation. Now, there is a little bit of debate as to the utility of resecting some of the hemosiderin-laden brain surrounding the cavernous malformation, in that those areas are, those kind of perilesional areas are thought to be affected by the excitotoxic effects of the blood products there, and that those might be epileptogenic. But that question is still on the table. There's kind of very really smart and careful people kind of on both sides of that debate. So a question that I always get asked is, is what about my family? Is CCM a hereditary disease? And there, while the huge majority of CCMs are sporadic, meaning that it just happened, there is a small subset of familial cavernous malformations that involves about 20% of cases, frequently involves multiple lesions. And when it is familial, it is inherited in an autosomal dominant fashion, meaning if one of your parents has it, you have a roughly 50% chance of having it. A lot of really nice work has been done by a few pioneers in this field. I'm happy to say neurosurgeons, neurosurgeon scientists who have identified some frequently identified gene mutations that are associated with familial CCM, and have further gone on to identify specific pathways through which these gene mutations alter alter protein expression and function, and kind of have really done the yeoman's work in kind of identifying how CCMs occur. I'm going to go over that just a little bit later on, just because it's so interesting. So then the next question that I'm always asked is, well, what are the treatment options? And it's important to always identify observation as a treatment option. You don't have to do anything about these. And very frequently, depending on the location, depending on whether the lesion is hemorrhaged, whether it's causing any secondary problems, very frequently patients are better off just leaving it alone. Essentially all asymptomatic lesions are left to observation. You don't, almost nobody recommends treatment for these lesions if they're not doing anything, they haven't hemorrhaged. The question then is, well, when is the right time to jump in and resect one if a patient has had one symptomatic hemorrhage, more than one symptomatic hemorrhage? What if it's causing a neurologic problem that's getting worse? What if it's causing epilepsy? And these are some of the most common reasons why we offer treatment for cavernous malformations. Wouldn't be a neurosurgeon talk if I didn't show some operative pictures. So this is just an example of what one looks like intraoperatively, and you can kind of see very towards the back of the brainstem there, some yellowish looking brain, which is the hemosiderin staining around a lesion, and it has kind of a darker, what we describe as a mulberry-like appearance. And you can kind of see a little bit of that just coming right up to the surface of the dorsal brainstem there. And then here's the lesion kind of dissected right around the outside, and it's, as you can tell, it looks basically just like a mulberry kind of coming out. And that's now that is gone. So what if you don't want surgery? Are there any other options? You'll hear about some other treatment options that are currently undergoing study. None of these have nearly the same kind of efficacy, safety profiles that have been kind of documented in the way that surgery has. But stereotactic radiosurgery has been tried for this disease, but in general is very rarely recommended for these because of a surprisingly high risk of neurologic deficit and mortality. Now, one of the treatment modalities, alternative treatment modalities, gaining some notoriety is laser interstitial therapy, which is essentially just thermal ablation. So far, the groups that have done it have shown really promising results. It's mostly been done in the setting of epilepsy management. But in addition to showing some really nice early epilepsy control results, there's also been no detectable hemorrhages as a result of doing this intervention. From what I hear, the MRIs in general have looked and remained looking kind of clear of cavernous malformation. So there is the possibility that this represents a future treatment modality option, but that really is still in the early stages of study. And then finally, there have very recently been some clinical trials for medical management for cavernous malformations. Now, this is related to hemorrhage risk and not epilepsy treatment. And that's the epilepsy side is a different story. But some of the ones that you'll hear about most prominently are ones for involving propranolol, and then a couple of trials testing the utility of statins, a commonly used cholesterol control medication. There's a few other medications, Sulindax, Sorafenib, vitamin D, that have also shown some laboratory efficacy, and if testing continues to look good in kind of animal models, that may may reach clinical trials in the future. So we'll keep an eye on those. So I want to spend a little time just kind of addressing what the work that has been done. Again, this is really impressive science that's been done on a disease that's quite hard to study, regarding kind of the pathogenesis of these cavernous malformations. So just very briefly, there is a theory that cavernous malformations lie within a spectrum of capillary malformations that include developmental venous anomalies and capillary telangiectasias. And there are cases in which you see mixed malformations among these three, multiples of these malformations, and then kind of hybrids of these malformations. But in general, cavernous malformations are composed of capillary walls, kind of a really thin endothelial lining, thin fibrous adventitia, but missing elastic fibers and smooth muscle, which make these vascular malformations extremely tenuous in terms of their wall support and likely to hemorrhage. So here's a representation of what a cavernous malformation looks like. It's sitting in the capillaries between the arteries and the veins. Very frequently, these will be associated with a developmental venous anomaly, which is just a fancy word for a large vein, an abnormally large vein. And oftentimes multiple cavernous malformations can be seen coming from the same vein, much like these mulberries here. So some of this slide I took from a really nice study that was actually partially made possible by the Angioma Alliance and kind of their tissue and genetic resources, kind of identifying a kind of a Twohit theory about how these develop, in that there is a mutation in a gene, but since there's two copies of that gene, that both need to be affected somehow. And then in addition, these endothelial cells that are affected by these mutations, they grow kind of together in a bunch, in a clonal fashion. And when you have kind of clonal expansion of these mutant endothelial cells, they cause cavernous malformations. There are particular gene alterations, which I mentioned earlier, that have been identified and characterized. CCM1 mutations are seen in a few Hispanic American families, whereas the CCM2 and CCM3 gene mutations are most commonly identified in kind of the Caucasian population. These genes have been characterized to the point that each has been identified as affecting Rho kinase activity, and this is exciting because this pathway activated endothelial cells could potentially lead to pharmacologic intervention. And two of those possibilities are depicted here. first, simvastatin, which affects higher up in that the MEK3 rhokinase pathway, and then the potential for the use of ROCK inhibitors, which are currently being studied in glaucoma. We think that ROCK inhibition may act to restore endothelial cytoskeletal dynamics. And then there are a number of other medications which we know or have been testing in terms of restoration of kind of abnormal vascular endothelial growth. So these studies have kind of gotten at the question of, where do these come from? How do they form? But probably the most clinically relevant question is, well, what about the rate of hemorrhage, right? If someone's already developed a CCM, these things hemorrhage. Now they look like they grow, but in reality, it's just that they bleed on the inside. The effect can sometimes be the same. So this study was one of the most interesting I've seen in a long time. I was really excited by this study. Again, supported in part by the Angioma Alliance from the laboratory of Dr. Samuel Wad. But he identified Bcells as being critical to the maturation, but not to the development of cavernous malformations. Now, Bcells, if you'll remember, are one of the types of lymphocytes as part of the adaptive immune system in each of our bodies and activates antibodies. And so there appears to be an inflammatory component to the development of cavernous malformations or the maturation of cavernous malformations and potentially affecting the risk of hemorrhage. I'm going to stop there and leave a little time for questions. For those of you who have made it with me to this point, I appreciate your attention. Let's see. Nothing in the Q&A.
All right, perfect. So I have a couple questions that came in through email. The first one was risk factors of IVF for CCM2 women with one CCM that has not bled.
Okay, so IVF. So I'm going to try to start by specifically addressing the question, then kind of expand this a little bit. Now, in vitro fertilization, there are hormonal treatments that come along with that process, and none of those hormonal treatments have been specifically identified to increase the risk of bleeding from cavernous malformations. None that I know of have to this point been shown to be associated with a risk of bleeding in general. And then finally, when you talk about kind of just medications and cavernous malformations, while there are certain medications out there that can increase the risk of bleeding, those each of those medications, like even when you start them, it's definitely important to discuss that risk and your particular risks of that comes with having a cavernous malformation. It's important to discuss that on an individual basis because while even though some medications do increase some risk of hemorrhage, very frequently in those cases it's worth that risk for the gain that you're getting. So it's really an individual question. So let's see. I'm getting a few on the Q&A, which I'm, if you don't mind, I'm just going to get at those. So can microbleeds be seen on an MRI? Frequently, yes. Our MRIs these days are extremely sensitive for iron deposition, and so in a lot of cases, we'll recommend kind of just routine surveillance imaging, even if there are no new symptoms. And we very frequently expect to see changes in the way that a cavernous malformation looks. And we think that that is mostly because of microbleeds that have happened. So when could the medications in trials potentially be available for patients outside of those studies? That's a great question. So off-label use of medications or surgical equipment or whatever is really common in medicine. One of the factors that goes into choosing whether or not to use those medications and which medication is commonly cost or insurance coverage. And then also kind of safety profile. But assuming that it's a safe medication to use, and someone wants to try it, that's something that really needs to be discussed with the surgeon that's taking care of you, with your primary care doctor. There are some kind of health screening that needs to be done before starting these medications, but the thing about trials is we are running those trials because we don't know whether there's a benefit to the use of those drugs. And so it's just important to keep in mind that even though some of these, we talk about these trials as being extremely exciting, at the same time, like, we're doing them because we don't know whether they work, and sometimes it can be harmful. So, and we just don't know that. So trying a medication off label is a pretty involved process, but definitely it's something that is possible. Let's see. Here's one. Is a keto diet or modified Atkins diet better than medications for seizures? For focal seizures, definitely not. And then with keto diet, usually it's used in conjunction with other medical therapies for seizures in general, and typically not alone. Okay. Diet and inflammation. So this association between the immune system and cavernous malformations is only beginning to kind of develop. We're only beginning to understand it. And diet and effect on the adaptive immune system, in contrast to the innate immune system, it's not really affected. I think probably still the best possible diet advice I can give is as heavily plant-based a diet as you're willing to tolerate. Let's see. Can we develop new CCMs? So I apologize for not addressing this in my talk. This is a very common question. So yes, CCMs can develop. Now, we know that it is extremely unlikely to happen in the absence of some other vascular malformation or other CCMs. Now, there are a few things where we have seen CCMs develop, most importantly, kind of cranial irradiation. So, a little bit about UCLA's program for CCM patients. So, our at UCLA, we tend to do things in teams. So we have a team of 3 neurologists and 2 pediatric neurologists who have a particular interest in cavernous malformations. And so we very frequently follow patients in conjunction, and depending on their needs. In patients where there is a suspicion for a genetic predisposition or familial case, we work very closely with a geneticist who kind of will go over some of the testing and run the blood tests and do the counseling for that genetic predisposition. Yeah, and then in patients who need it, we also have kind of a neuro rehabilitation program here that we occasionally need to work with in CCMs, although luckily it's not that common. I've seen a couple of questions regarding CBD oil and its effect on CCM, and that is completely unknown. So with each hemorrhage, are the symptoms definitely going to get worse? Not necessarily. That's each hemorrhage kind of we have to treat individually and kind of evaluate individually. So I'm going to try to sift through these a little bit.
I have a couple questions that came through over the chat.
Oh yeah, go ahead, please.
Can CCMs disappear or reduce size on their own?
So CCMs, sometimes it's tempting to think of these things like tumors, but they are not. The imaging appearance is heavily influenced by kind of the signaling characteristics, the pattern of bleeding, and so sometimes you will see them change in size, like either reducing in kind of the imaging size or increasing in imaging size. And sometimes that's kind of just artifactual. Sometimes that's just kind of a happenstance of timing. So you will sometimes you'll see a lot of variability in kind of the imaging appearance of these lesions, and it doesn't necessarily mean that they are shrinking or growing per se, but rather just that the appearance is different. I have a really interesting question about connection between CCM3 and migrational disorders. So fortunately and unfortunately, CCMs are a rare enough disease that correlating that, kind of correlating the likelihood or kind of mechanism with other extremely rare genetic disorders has only recently even become possible. And so unfortunately, I don't have an answer to that question, although there are certainly several mechanisms where you could think that might have some relation. Sorry, Lindsay, you were going to say you have another one.
Yeah. How does the B cell T cell dynamic work affecting CCMs?
Okay, so far there's not really been an identification of kind of the effect of T cells on these. The T lymphocyte response is kind of a directed cellular cytotoxic response, whereas the B cell the B cell kind of response activates antibody response. It looks like that it's just the B cells that affect these. There's not been any indication in the literature that there is a T cell response that affects CCMs.
I have another one that came through email. This one says, my son, who is 16, has 42 cavernous angiomas. Can he lift weights? Also, when he gets upset, I get scared that it's putting pressure in his head. Is this true?
I'm sorry, would you mind repeating the second part there?
Yes, when he gets upset, I get scared that it's putting pressure in his head.
Yeah, that's a really common fear. You're in very good company. So with my patients who have cavernous malformations, very generally my role is to help my patients live the life that they want to live. And as high quality for as long as possible. And for most people, that means a full, unimpeded life. And I think that in a lot of situations, that exercise that they're getting, whether it's lifting weights or running or cardio or whatever exercises they want to do, in most of those cases, that exercise is far more important, those benefits are far better proven than any benefit that might come from rest. And that is to say, there is no evidence to suggest that avoiding physical activity reduces the risk of hemorrhage or symptoms or neurologic deficit with CCMs. And so what I tell most people is, there's a lot of evidence to suggest that exercise is extremely beneficial for your health long term, and there's no evidence to suggest that exercise is detrimental to your health because of CCMs. And so I recommend that patients exercise in essentially whatever way that makes them happy and gets them out there doing it. With regard to pressure in the head, these things, most of their effect on surrounding brain is from irritation, partially due to inflammation, and really not like a mass issue. And so I just want to kind of reassure you about the pressure, that pressure concern. That is not something that we really that really plays into CCMs and the way that they affect people. Can a person with CCM fly on a plane? Absolutely. Cabins are pressurized, and then plus the cranium is a pressurized system in and of itself, and so flying is not an issue. Then can hemosiderin reabsorb after a hemorrhage? So those blood breakdown products are slowly reabsorbed, but there is essentially always some residual deposition of blood breakdown products that aren't kind of cleaned up by the macrophages in that area, microglia within the brain. Okay. Any connection between CCMs and headaches? CCMs can cause headaches for sure. Any kind of bleeding in the head can cause headaches, including from CCMs. The thing to keep in mind is that there are also many other causes for headaches, and so sometimes, when you're dealing with both the CCM and headaches, there are cases where the headaches are contributory. There are cases where it's basically true and unrelated, and then finally, you're also left with what the available interventions are. Just because we know that's causing the issue doesn't mean that we can necessarily do something about it. And then, the kind of natural next question would be, well, could you do surgery and will that affect the headaches? And I think I think that would be dishonest for me to say that I would expect doing surgery would affect the headaches beneficially in any way. Lindsay, any other quick questions you found in there?
Yes, it says, so why does the risk of hemorrhage increase with age, or does it?
So this is a very interesting question. Statistically speaking, there is some indication that there is more hemorrhage with age. But then, the question being why, and I have no idea why. There are obviously many reasons why that might be, including just general health, vascular health, associated medications, that sort of thing. And then there's this whole maturation and eventual kind of decline in the function of the adaptive immune response as we age. So, while we think that there may be a slight increase in risk of hemorrhage with age, I have no idea why that happens, but that is a wonderful question.
All right, let's see. I can feel a tingling numbness in my tongue when I exercise. Is that a negative? Is my calf responding negatively to the exercise? Or is that a good assumption, a logical assumption?
Numbness and tingling. I'm sorry, one more time, please.
Basically numbness and tingling in my tongue when I exercise. They're assuming that's a negative sign, or that their calf is responding negatively to the exercise.
I'm sorry, I'd have to know a lot more kind of specific information about that condition before I could really say before I could say anything useful there.
Okay.
If that malformation were in the right location and were clearly the cause, that doesn't necessarily mean that there's something going wrong. That may just be you. So I as long as it's happening reliably, but it's not it's not causing any problems for you, and you've discussed it with the doctor who's taking care of you. I think I have a hard time kind of coming up with a reason why that would be bad. I have a good one here. As far as I'm aware, the main modifiable risk factors for CCM1 carriers are obesity, alcohol use, and tobacco use. Are there other risk factors that to point out, such as caffeine consumption, anaerobic exercise? I hope that I've addressed some of this question already. I think the kind of statistically identifying modifiable risk factors for hemorrhage in a condition this rare is really difficult to do. I always try to kind of limit the advice that I give, or at least distinguish between what I think and what I know. And so if I'm to talk about what I know, I don't know what the modifiable risk factors are. Now, what I think, and what I advise to patients is that kind of the things that affect your general cardiovascular health: chronic uncontrolled hypertension, high blood pressure, uncontrolled high cholesterol, uncontrolled high blood sugars. Those are some of the factors that are that in my mind are much more likely to affect kind of long-term health. And you identified tobacco, which is super important. So I don't think that kind of moderate caffeine consumption really would have any effect if in outside of the setting of chronic uncontrolled high blood pressure. And then like I said, any exercise is good. There's really no evidence to suggest that anaerobic exercise or aerobic exercise increases risk, but for sure those are beneficial for your long-term health, cardiovascular health in general. Let's see. I love this question. So if my CCM has oozed, am I saying that there's no real risk of it bleeding from hanging upside down, doing dance, or riding rides at theme parks? So again, I'm going to kind of differentiate between what we know and what we think and what I think. That there's not been any statistically identified increase in risk of hemorrhage from position, body position, activity, G forces. What I think is I think that those are extremely unlikely to have any effect on these. It just in that, you know, when throughout the day, we have temporary increases in blood pressure, temporary increases in intracranial pressure, the surrounding brain pressure unrelated to blood pressure. We have all sorts of positional changes that we go through. And none of those are inherently different than riding a roller coaster ride or hanging upside down or doing yoga. So what I think is that those activities are just fine. And does a hit to the head potentially cause a hemorrhage? When I advise patients, I usually advise them if their livelihood isn't dependent on playing football or rugby, that they don't do it. But the truth is, I don't actually have any basis for saying that either. So I hope that answers the question. And is there a greater risk of bleed at high altitude? Not that we know of. Not that I know of. And I wouldn't think that barometric pressure would have anything to do with that. In terms of oxygen tension, I can't really think of a reason why. A question about menopause and hemorrhage risk. So yeah, those again, with the hormonal changes that occur during menopause, you know, it's kind of similar to the IVF question. It's like, yes, there are a lot of changes that occur there. Very few of those have any suggestion of an association with hemorrhage risk in general, or bleeding time, or coagulation. You know, those are actually very frequently associated with a higher risk of coagulopathy or hypercoagulability. And then kind of similar with the birth control pills as well. I saw a question about that. So to the best of our knowledge, there's not an association with menopause, birth control pills, IVF, and hemorrhage. And then do activities that increase ICP predispose to CCM bleeds? Not that we know of. If anything, you would think that it would actually reduce the risk, but no, it's ICPs change drastically over the course of you know, seconds to minutes, over the course of the day, at night, at rest. There's not much reason to think that affects the risk of hemorrhage. So, all right. I hope that I've you know, answered most of your questions to at least some satisfaction. And again, I'm very happy to address more questions. But I think that I should probably sign off. And I really appreciate your attention and for coming to join me today.
Well, thank you. On behalf of Angioma Alliance and the CCM community, thank you so much for taking time to speak with us today.
Oh, wait, I'm sorry. Sorry, Lindsay. I got a really good question that I just wanted to address just a second.
Sorry, go for it.
Someone asked about vaginal delivery versus C-section when you have CCMs, either singular or multiple. And this is a question that comes up all the time. And the truth is, you're going to get different advice from different doctors. Now, there are, as far as I'm aware, there are no official recommendations either through the field of obstetrics or through the field of neurosurgery with regard to kind of perinatal management. Now, if you extrapolate CCMs to other vascular malformations that have been a little bit more kind of intricately studied with for this question, those all say that kind of obstetric concerns should guide your treatment of, your selection of delivery modality, and that you shouldn't, necessarily choose C-section over vaginal delivery for those lesions. I'm thinking about like arteriovenous malformations, certain tumors, that sort of thing. Now, for CCMs, I don't think that there's a lot of reason to think that, to suspect that the reason or that the risk of hemorrhage would be any different than for AVMs. And so for my patients, I recommend that they make their selection based on obstetric concerns and personal you just do personal preference. And to the best of our knowledge, that there's not an increased risk of hemorrhage with vaginal delivery. But you will definitely hear varying opinions from doctors on that topic. Okay, so again, thank you very much for joining.
Oh, thank you. Thank you for taking time to speak with us. All right, have a good night.
Bye.